Hello. Good afternoon, everybody. Welcome back. Welcome to day 3 of EMS Conferences here in Bali, Indonesia. I trust you all had a wonderful afternoon off yesterday. Did anybody have a few too many bintangs? Did anybody go on a tour anywhere? Did anyone hike any mountains? Nice. Awesome. I'm glad that you're enjoying what Bali has to offer. So just in line with the themes for the last 3 days of this conference, we will be doing our Instagram competition again. So do we need a reminder on how that works, or are we okay? We understand that the loudest cheer wins. Is that clear? Let's get started now. So this is our first entrant into today's door prize. Happy with that one? Okay, next up is this lovely photo from, I'm going to say that is Motel Mexicola. So can we judge that one, please? Oh, I like this one. Can we get a round of applause for this next one? Oh, that's a nice one. At Paddy Harmon. How'd that get up there? Can we get a round of applause for this one? That's so weird. Oh, this is nice. Can we get a round of applause? Oh, that's lovely. This is Sky again. I don't know where this is. I'm going to say that's down at Seminyak Beach or somewhere like that. Where? Kuta. Nice. At Kutata. Oh, I also went there. Can we get a round of applause for this? And I think this is our final entrant. All right, so I'm a bit confused as to who won. So I think it's between this one, and this one. So this is our final 3. So remember, loudest cheers wins. So once more for Tanya's cow posting. Now. Not that one. Fiona's. And the ATV tour. I think the ATV wins, so if you are the owner of this Instagram post, Keely Ashton, then come and see us at the break or afterwards. But before we go too much further, I would like to get to this afternoon's sessions underway, and we're really, really privileged to welcome this next speaker to the stage. All the way from the United Arab Emirates is Dr. Hamid Chatha, trauma and emergency physician based out of, as I said, the UAE, who's going to provide a special insight into controlled resus in trauma patients. Make him feel very welcome.
Good afternoon. Thanks very much for having me, and it's great to be here in this lovely city of Bali among all of you. It's been a fantastic time we had so far, and hope to have a good one next couple of days. I have no disclosure in connection with my presentation. I would like to ask you guys to scan this barcode and answer this question for me to kickstart this discussion about controlled resuscitation in trauma. Right. Answers have started coming in. Excellent. Okay, so this gives me an idea, a starting point that the understanding of my audience about controlled resuscitation trauma, and most of you all guessed it right. Okay, so show of hand, how many people in this room have been in this kind of situation? Okay, maybe like this one, another extreme. And if it's an office place, you have this kind of scenario where people are doing different stuff and nothing is organized. And lastly, I think this will resonate with Bali people. What do you think? Okay. So what is common in all these three slides is lack of control and the chaos. It might be okay when it comes to normal circumstances, office space in a school, but when it comes to the resuscitation, it is very important that we have an organized and we are controlled to have a good outcome. Control gives us a safety, efficacy, and increased productivity. So we have a case. You have a 35-year-old gentleman who's going to come to the hospital as he had a road traffic accident, head-on collision. He did not have a seatbelt on. One passenger died on scene. When you hear this kind of scenario, what comes to your mind? What comes to my mind is that this patient is going to be very sick. He's going to have a multiple injured systems and is going to be challenging to manage. I have been managing trauma for more than 15 years. And when I hear this kind of pre-alert, I feel like emotionally overloaded and cognitively disturbed. My heart is pumping and adrenaline is rushing in. So the question arises, what is the best way to manage these kind of patients? So here today, I'm going to share with some tips and ideas which we can focus on to improve the successful outcome of a trauma resuscitation. So controlled resuscitation is a resuscitation which is carried out in a systematic approach which minimizes errors and mistakes and delivers fast and effective treatment for your patient. So I imagine most of people sitting in this room have some sort of trauma experiences, and you know your primary and secondary surveys as taught by trauma courses. But there is another survey which is called 0-point survey, which is important too. So that 0-point survey was first documented by Dr. Cliff Reed and his colleagues in 2017, but it has been around for at least 2 decades. And they argued that it is important to take some steps to be prepared. And those steps are to optimize the safety, to increase the performance, and set the stage to execute a first-class team performance while managing trauma. Even in the most time-critical situations, you should be able to create an environment where you can enhance the safety, do a self-appraisal, and do a little bit of pre-trauma arrival meeting. It basically focuses on 4 domains. It includes self, team, environment, and patient. If you focus on these 4 domains, you should be able to have a process where you can have a most likelihood to achieve successful outcome. And the aim is to create an environment which is a best for a best team to perform and a best outcome for the patient. And on the trauma resuscitation scale, you want to be on the right side where you achieve an excellent outcome. So we do resuscitations in emergency departments, but as you guys know, the resuscitation actually starts way before the patient arrives to the hospital. It actually starts on the scene. So I would ask you to scan this barcode for me and answer this question. Why is control of scene emphasized in major trauma? Thank you very much. So to ensure the safety, control hazard, prioritize life-threatening hemorrhage. So the first step to have a controlled resuscitation is to control the scene. If there is only single vehicle involved or a small trauma scene, it's much easier to control. However, if you have multiple cars who have involved in road traffic accident, or it is a disaster scene, or a block of house on a fire, it's going to be really challenging. So the most important thing to start with is to control the scene. You have to cordon off the area. Only authorized person should be in and out. You have to make sure that your staff and your patients are safe and to prevent for any secondary injuries. For example, after road traffic accident, if fire breaks out, you have to preempt these kind of things and make sure that these things does not happen. For medical legal purposes and for the police, you have to preserve the scene so that they can get the evidence. And on the scene, you have to set up the triage if there are many casualties to prioritize the transfer. Once you have organized your scene, and obviously you have to do some life-saving procedures at scene if time allows and if there is a need of it. And the next step is to transfer the patient safely to the hospital. And that is important because that should be done in a manner where patient should reach the hospital in kind of semi-stable condition, and hospital people will have a time to work on it. So make sure that the airway is protected, any active hemorrhage has been controlled, and if we can get an IV line, that will be wonderful. There are two thoughts of transferring patients to the hospital. One is a scoop and run, and the other one is a stay and play. The scoop and run idea takes precedence and it's been recommended most of the time, where you just pick up the patient and move it to the closest hospital. But it should be done in a way that is safe, not ending up in another accident. So, and stay and play is applicable in some scenarios where you have enough resources and people who have enough competencies to do some procedures on site. For example, in London, they have pre-hospital services. They have a trauma surgeon on board with pre-hospital people. So they do thoracotomies on scene and then transfer patient to the closest trauma center. So it's important that you know about your logistics and equipment and expertise before making that decision. However, scoop and run is the main idea which should be applied. And then you can decide that the patient needs to go which kind of hospital. If you have a smaller hospital closer by, you might have to bypass and go to the major trauma center which can deal with all these injuries. So trauma code has been activated, and some big people with big personalities and egos are going to come down and help you, allegedly, in resuscitation. And you have to control them. If you cannot control them, that's going to be not working very well. So you have to control them. Before that, you have to control yourself. So lead yourself first and lead your team later. It's very important because you have to be in kind of frame of mind and a mental space where you control your emotions and thoughts very well. And if you can do that, you're going to be successful. Your posture, your eye contact is going to give confidence to your team to believe in you. So that will be a good beginning. You have to be in we mode rather than I mode. I mode means a leader who is bossy. He wants orders to be followed without any questions, focusing on personal goals and power. While in we mode, people are more inclusive and collaborative. They work as a team towards a common goal. So aim to achieve a vui mode, and that works very well in team scenario. So once the patient is still coming, you starting your shift in the morning, in trauma scenarios or in any resuscitation scenario, you need to go and make sure that your resus is in place. This picture looks pretty messy at the moment, not very well organized. So you need to make sure that you have enough staff on the shift who can give you hand in case of resuscitation scenario. You have your equipments. For example, your ultrasound machine is working. You have level 1 transfuser, which is in working order. You have enough blood in the fridge. You have airway drugs and equipment ready, and so on and so forth. So you need to make sure that staff check your equipment, put the trauma call early, and dedicate somebody to look after the family members if they're coming in, because their needs really helpful to support them and brief them what's been going on. Once the team arrives, controlling team is very important. You need to know your team. So how you know them? You have to introduce each other. Sometimes if you're working in a hospital, you know most of the colleagues, but sometimes new colleagues join in the teams as well. So important to know their strengths, weaknesses, and the word is competencies. So you can allocate the role appropriately. You have to draw the lead lines. You need to nicely explain them assertively that who's the team leader and whose order should be followed. And you need to control the scene and people. So whenever I have a trauma code, I have my own 6-7 people. Then I have 3 student nurses, 2 medical students, 3 paramedic students. So too many people. So you have to control them. So you have to see that there should be enough people which you need, but too many or too little are too bad. So this picture just tells you how many people we should have on a trauma team. So if you have a good number of hands available, you should have 8, excluding surgeon and radiographer. And if you're short of people, it can be done with 6. Obviously, sometimes you might have to do with a little less, but these are the people where you can get with good outcome. Right. Most of the time, in a modern healthcare system, we work as a team. Sometimes you might have to work alone to resuscitate a trauma patient. Hence, team dynamics is very important. And for high performance team, there's a lot of emphasis on good leadership and teamwork. For example, on this picture, F1 pit stop, how quickly they change the tires. And that is due to a teamwork, and which has been rehearsed and practiced over and over again, maybe hundreds of times, and they are just competing for milliseconds to improve on it. So we doctors and trauma managers, we need to work, we need to run simulations, we need to practice ourselves so that we get in the mode that where things become natural and we work as a team. There are some characteristics which high performance team should have. Anybody can name some of these, please? Leadership, yeah. So clear roles and responsibilities. So team leader, once you introduce your team, you allocate them roles and responsibilities according to their competencies. Positive intervention, constructive intervention is that, for example, you have a trauma patient, you did an initial fast scan which was negative, and a colleague of yours who's a team member after 10 minutes suggests that should we repeat the ultrasound scan just to see if is there any change. Knowing your limitations, knowledge sharing, summarizing a reevaluation, that's a part of reassessment, closed loop communication, clear messages, and mutual respect. And mutual respect is a very important, and that has to be gained with the way you behave, the way you lead, and your competencies. And people will believe in you if you're leading the team. Okay, coming back to the case. So patient arrives, he's agitated, he's not keeping oxygen mask on. So if the patient is agitated and not keeping mask on, that's red flag for me. His pulse is 125, his blood pressure is 90/60, respiratory is 26, and oxygen saturations are only 90%. Right. So at this stage, I'm thinking, what is my first priority? I think at this point, it's important to keep yourself and your team safe and your patient safe. and we have to control our patient. To control our patient is very important. We need to know why he is agitated. There are many reasons a trauma patient can be agitated. It could be shock, could be hypoxia, it can be traumatic brain injury, could be drugs. So there are multiple reasons it can be agitated and can be very difficult to evaluate in the first few seconds why is he agitated. So you need to make sure that control the patient. How are we going to do that? Only one thing coming into my mind is medication-wise is a ketamine, which will rarely things go wrong. You use it, you'll be fine. You can sedate your patient. It can give you some analgesia effect. And if it's not enough, if patient is still agitated and it's not combative, using foul language, don't shy from intubating the patient, because you have to take this patient for trauma scan. And if he's moving, it's not going to be easy to scan him. So intubate early if needs. Right, last poll of today. In controlled trauma resuscitation, the main goal of hypotensive resuscitation is Thank you very much. Excellent. So majority of you again right. Hypotension is your enemy while resuscitating a trauma patient. If you're gonna focus on blood pressure for somebody to diagnose he's in a shock, then you're gonna miss the boat, because you have to lose 30% of your blood volume before the blood pressure drops. For me, if a patient is hypotensive, is in shock, if he's cold and clammy, until proven otherwise. So a patient who's a cold and clammy, you should think he's in a shock. Trauma patients, specifically penetrating trauma, most important reason of shock is hemorrhagic shock. And the common mnemonic is floor and 5 more, where the patient is losing the blood. Is there blood on the floor? Is there obvious bleeding? Is he bleeding in chest, abdomen, pelvis, retroperitoneum, or long bones? So it's important you can locate why patient is hypotensive. Hypotension is no good for the patient. It increases the mortality. And we know that while we're managing patients, the blood pressure cuff is not going to be very accurate. And all the time we see that in shocked patient, sometimes blood pressure is 180 and next minute is 80. So if you have a hands available, try to get arterial line early. Another way to kind of diagnose patients who are in shock early is to use shock index, which is very good picking up the patients who are in shock before the blood pressure drops. It is heart rate divided by systolic blood pressure is equal to shock index. It ranges from 0.6 to 1.4. More towards 1.4 is bad, 0.6 is normal. Okay, I will be worried if somebody have a shock index of 1. It tells you that number 1, patient is going to need a blood transfusion in a good amount. Number 2 is going to need an ICU admission. Number 3 is mortality quite high. So you should be worried about your patient. Permissive hypotension, hypotensive resuscitation is a concept which has been around for years now, where we try to achieve low blood pressure than normal, specifically patients who are bleeding. And so that we can have enough organ perfusion, but we can preserve the clot and blood volume. In the meantime, we can achieve the definitive treatment, which is to control the hemorrhage. So the target blood pressure in people who have permissive hypotension is around 90 to 100 mmHg. And the other people who does not have an active hemorrhage going on, the blood pressure should be close to 110, specifically people with traumatic brain injury. So now the patient is having hemorrhage, so you're trying to control the blood pressure. And to control the blood pressure, you have to control the blood volume. To control the blood volume, we have to transfuse blood because patient is losing blood. In past, we have used crystalloids and colloids. Again, for last 10 years, started moving away from crystalloids. You give them a blood as soon as possible. Pre-hospital services carry blood with them and they start sometimes pre-hospitally. You can still start fluids if blood is not available, but try to minimize crystalloids and start blood early. In recent years, there was a SWIFT trial where they've used whole blood rather than blood components, and it has shown that significant improvement in outcomes in trauma patients. So the trend is to give whole blood, which is low titer O blood. And if it's not available, then obviously you should use RBCs, platelets, and FAPs in 1:1:1, and that can be still used to carry on the resuscitation. You have to control your fractures. It is important because we know that long bones, pelvis can have a significant blood loss. In pelvis, you can leave more than 3 liters. In femur fractures, you can leave 1.5 liter of blood, and in tibia, you can 750 mils of blood. So if you control fractures, you realign them. Number one, you reduce the bleeding. Number two, you will improve the pain for the patient. Coming up to the pain, be generous while controlling pain in trauma patients. You can use ketamine without any problem. If the blood pressure allows, you can use fentanyl, but don't ignore this aspect of that might be the reason your patient is agitated. Controlling acid-base balance and lactate. Your patient is hypotensive, he's in a shock. Reduced perfusion to the tissues leads to high acid in your blood and lactate, and that obviously is poor outcome for the patient. Monitoring acid-base balance and lactate is the kind of endpoint in trauma resuscitation. If it is improving, we should be happy or confident. If it's not getting better, you should be worried about your trauma patients. Acid-based balance and high lactate due to reduced perfusion leads to a decrease in cardiac contractility and cardiac output, and hence worsening your shock scenario. You should think about coagulation. Check your PT-INR and coagulation profile. Don't forget tranexamic acid. We know from crash trials that giving 1 gram of tranexamic acid within first 3 hours and second 1 gram over 8 hours improves the outcomes. And in traumatic brain injury, NICE guidelines recently recommended 2 grams can be used as a bolus to start with. And coagulation will go bad because of use of clotting factors. Number 2, because of hypothermia. Number 3, giving fluids. That can lead to dilutional coagulopathy. So these are the reasons that coagulation go worse. Controlling temperature is important too in trauma patients because they will lead to coagulopathy. You should remove any wet clothes if they have any. You should give them warm fluids and run blood to the level 1 transfusion so that temperature is controlled, so that it doesn't affect the coagulopathy. So acid-base balance, coagulation, and temperature management, these 3 make lethal triad of death. So you have a trauma patient, you have a hemorrhage, and then hypothermia kicks in, which leads to acidosis and coagulopathy, and then this vicious circle goes on. We don't want to be ideally in this situation, but if you are there, then you need to make sure that you take appropriate steps to reverse this one. Because if you have these 3 things present in a trauma patient, the mortality is more than 80%. It's our duty as a doctors and physicians and other colleagues that you should be controlling radiation for your colleagues, for your patients. For the physician and emergency department, you should only be ordering the necessary investigations. And the radiographer, is his duty that he should be getting the good quality images with as low as radiation possible. So the principle is ALARA, as low as reasonably achievable. Control your blood sugar, make sure that don't ignore it, because it's important that, again, agitation could be because of hypoglycemia. Damage control is a concept which has been around for years. It came from maritime agency, where you stabilize the patient and then you take them to ICU, and then later stage you take them for definitive surgery. What happens, you have a first hit, which is a trauma, and that will lead to a systemic inflammatory response. And if you take them to the operative room early, that will put a second hit on the patient, and systemic inflammatory response will go really high, and that has shown that is an increased mortality. So important that if the patient's condition allow and the injuries are not life-threatening, you should stabilize the patient, give them a rest, stabilize them in an ICU, and then take them to OR or operative room at a later time, a few hours down, or maybe the next day. At the end, control goals of your management, what you want to achieve in that patient. So you need to be, discussing with your team once you know the patient's condition, what's going to be endpoint of your resuscitation. Is there time when you have things to let go, when you know that this patient resuscitation is a futile? For example, if you have a gunshot wound to the head and chest, his brain matter is out, there's no point doing thoracotomy in that patient. You need to make sure that if the patient is unstable, he needs to go to operative room rather than take him to the CT scan, and you need to think about alternatives. Our intervention radiologists are very good nowadays, and they have reduced the burden on our surgeons quite a lot, and they can do so many fancy things and embolize vessels to control bleeding. So think sideways. So in summary, you have to focus on 4 systems, which is self, environment, team, and patient. If you focus there, you should be able to get a successful resuscitation team. Thank you very much.
Thank you, Dr. Hamid. We do have some time for some questions from the audience if anybody has anything to add or ask.
Thanks for a very nice talk. In your practice, do you use like a balanced ratio of blood products, or do you follow any form of ROTEM guided or take derived sort of resuscitation?
Well, ROTEM is quite good, useful, test to be done, but this unfortunately is not available everywhere. So we have available in our institution, so we use it, and it can be quite handy to give you an idea that where the patient's coagulation is going, and you can take in early steps to manage coagulation. So as I said, it's useful, and it should be used if available.
Thank you.
Any further questions? Thank you, Hamid. That was really insightful. I think we can all reflect on times where the chaos has got the better of us, and that highlighting that importance of collaboration, cutting through that chaos is really beneficial for us all to think about. So we're just going to take a couple of minutes break now just to top up our cups of teas and coffees and go to the toilet if needed. There's still plenty of food available, so make the most of the catering from the wonderful staff here at the Trans Resort while we can, and meet back here in about 5 minutes or so. Thank you.
Yeah?
Okay, thank you everyone. I'll just give people a couple of seconds to resume your seats. Okay. Also from the United Arab Emirates, joining us from Dubai, Dr. Anser Mahmood is here to decode, the dizziness. Please make him feel very welcome.
Good afternoon. Sorry, it's always great pleasure to be here. And it's always a tough job to come and speak after Dr. Hamid. You know, it's like you've been asked to bat in a tense T20 game when Maxwell just got out. I'll try my best. Next 30 minutes, we're going to talk about a common ED presentation called dizziness. The reason I chose this topic was I never been good when it comes to assessing a patient with dizziness. So whenever, when I was a resident, there is a dizziness case in our IT system on our computer, I used to disappear here and there and waiting for somebody else to pick that patient so that I don't have to see it. So I thought, let's just decode it and see if we can make things easier and have a structured approach for people, especially who are working on, I hear that lots of our colleagues in this conference is working in pre-hospital settings. Some are in remote clinical areas where you don't have much, new fascinating pre-Tesla MRI available. So if we can have a systemic approach and have a structured clinical approach, how to assess dizziness, I think that will be useful. Vertigo, always a difficult symptom to assess. The part of the world where I work, it's a very common presentation. After 10 p.m., when you are at ED shift, every third patient comes with dizziness. And without being feminist, most of them young ladies. A little bit of background. The large systemic review showed that most of the ED presentation with medical acute symptoms sometimes present with dizziness. They say 3 to 10%. I'm not so sure. I think it's much more than that. If we ask ourselves in this room that how many of us has ever in life felt a brief episode of dizziness, I think maybe we'll say every third would have had the one of the symptom at some point in their life. And we all are very young, long life ahead, and I'm sure if people who did not have would have it some point of their life. Interestingly, the vertigo presents around 12% of neurological emergencies in ED. That's actually quite a lot. And sometimes it is extremely difficult to differentiate between a vertigo from other causes of dizziness. And this I quote, this last statement is from UK. So apparently ED physicians are not great in assessing and diagnosing somebody with acute dizziness. I'm sure probably Australia and Southeast Asia will be far better than us. So let's start with a case. You have a 65-year-old lady who presents with the ED. She doesn't feel very well. She has acute vertigo. She feels nauseous. And you see this. What do you think? Nystagmus. What sort of nystagmus do you think it is? It's a horizontal nystagmus. Now, when it comes to dizziness and vertigo, people have different definitions and different way of presenting this to the physician. Most of the time, it's extremely difficult to suss out what exactly patient is trying to tell you. So different scenarios, some people present as a presyncope, some says lightheadedness, some says dizziness, and some are very, very imbalanced. They're disequilibrium, and essentially they say they cannot walk. Honestly, sometimes it's extremely difficult to delineate what exactly they are trying to tell you. But let's see if in next few slides, if we can have a approach how to actually get a good history and examination. So what is vertigo? It's essentially a strong sense of motion or spinning. Now, then if that is the vertigo, what is disequilibrium? So disequilibrium comes as loss of balance without any head movement. So you can also call it dizziness of feet. And then lightheadedness, usually feeling as if they're going to faint, which sometimes is extremely difficult to differentiate between presyncope and lightheadedness. So with all these symptoms and different kind of scenarios, it makes the ED physician job extremely tough. And you can imagine why I was so scared of going and seeing a patient with dizziness, because essentially there's a broad spectrum of underlying conditions which can present. It's ranging from benign, which is luckily most of the cases, but sometimes it could be life-threatening. So as an ED physician, our job is to make sure we identify those patients who are high risk of having something significant or something critically unwell with them. Two main divisions is either is peripheral, which is 92 to 95% of cases, the causes of dizziness and vertigo is peripheral, which is quite reassuring. But there are 5 to 8% of cases where the cause is a bit more serious and can be life-threatening. So what are the common causes of peripheral vertigo, peripheral dizziness? Most of us would have heard these terms: benign positional vertigo, labyrinthitis, vestibular neuritis, Meniere's disease, acoustic neuroma. Some people say acoustic neuroma is central cause. Others will argue, no, it's a peripheral. But usually it is counted as a peripheral cause of dizziness. And then more central, which what we as an ED physician want to rule out, that this is not the case in your patient which you're seeing right in front of you. Just cerebellar strokes, brainstem infarctions, TIAs, Budd-Chiari syndrome, and especially young female multiple sclerosis. So this is a general overview of pathophysiology track, which usually is the underlying culprit of patients with vertigo. You'll see it starts from your labyrinth system, which is vestibule and utricle, and then vestibulocochlear nerve, and then midbrain and cerebellum. So how do we assess? The first thing we do in EDs, we assess our patient by ABCD system. Luckily, most of the time, the airway breathing circulation is fine in those patients, but you would see some patient on and off. They come in, they're very dizzy, young, huffing and puffing, and making everybody go very nervous. Most of the time, these young people actually don't have anything sinister, and it could be other reasons, sometimes psychological, sometimes other underlying medical issues which is causing. But most of the time, the ABCD is fine in those patients. So on that slide, we looked at nystagmus. So once you've taken the history, the first sign you want to identify, is this patient, my patient who is dizzy, does he have a nystagmus? And if he does have nystagmus, is it sort of indicating the peripheral pathology or central? So usually peripheral is unidirectional, they're horizontal, so oscillating horizontally. When you fix their vision, it sluggishes or it stops. And it does not change the position. So it always unidirection. And the central nystagmus is usually purely, it could be torsional or vertical, but there are some cases where the central cause of nystagmus could be horizontal also, but mostly vertical and rotational. It does not fix with so if you fix their gaze, the nystagmus will go on, it will not fatigue. And it would change with the direction. When I mean by changing direction, usually with peripheral, if patient look on the left, both eyes will move towards the left. But in position changing, if they look at the left eye will go the left. But when you move to the right eye, instead of going to the left, will go to the right also. Those are worrying signs of nystagmus. How do they present? So the patient can present with different ways. They can present first episode of prolonged spontaneous vertigo. They can present as paroxysmal recurrent, so keep happening after every 2-3 years. If you take a history, it has happened in their life in the past. Then a number of both central and peripheral causes of vertigo may present with first episode of prolonged spontaneous vertigo also, especially cases with acute vestibular neuritis, benign positional vertigo, and cerebellar strokes or TIAs. Vestibular neuritis. So some people mix up with vestibular neuritis and labyrinthitis. They are two different things. In vestibular neuritis, is usually inflammation of the vestibular nerve only, which could be viral, could be underlying MS or any drug toxicity. It lasts for minutes and hours. It just does not go in the seconds. It's actually prolonged, exacerbated by head movements and no other neurological sign. And the nystagmus is unidirectional and it suppresses with the gaze fixation. Usually fast phase of nystagmus is away towards the problem. So if it's the problem in the right ear, the fast phase of nystagmus will be the other side. Just a picture. I hope you guys are not dizzy already. And then paroxysmal vertigo. It then represents as two forms, A, without hearing loss, which underlying cause could be TIAs, benign positional vertigo, and migraines, and with hearing loss, underlying condition, Meniere's and acoustic neuroma, which we will discuss in a minute. So acoustic neuroma is a tumor or schwannoma of vestibulocochlear nerve, and usually it presents slow, it's very trivial symptoms. It's not insidious, it's just very slow, progressive symptoms of dizziness and hearing loss. Associated with tinnitus, and sometimes it also gives you facial numbness. A little bit of digging down and unwinding between Meniere's, labyrinthitis, and vestibular neuritis. So Meniere's usually increased pressure in endolymph. So patient feel his ear is quite full, comes with tinnitus, with hearing loss, but no underlying URI symptoms. Labyrinthitis is usually viral, and it involves whole labyrinth. So difference between labyrinthitis and neuritis. Labyrinthitis, you will lose your hearing. In vestibular neuritis, hearing spares. And then acoustic neuroma, as we already mentioned, unilateral, slow progressive hearing loss with possible facial numbness. Most of our cases are benign positional vertigo, which is quite reassuring. It's something which could be very annoying for the patient because it's recurrent. When it happens, you feel awful, severe nausea, vomiting, sweating, but as a patient, as an ED physician, you can be rest assured that this is not something which is serious. Those episodes last very briefly, few seconds, something called as motion onset, so things which you stop and walk. For instance, you're in the bed, suddenly turn your head, or you extended your neck and sudden onset of dizziness and then it disappears. People who use a lot of escalators or elevators, they stop and then suddenly go on this and they feel they're dizzy and they're going to go. Those cases, we usually, when they come to ED, they probably don't have dizziness, they don't have nystagmus, and what we do, we'll do this Dix-Hellpike test to ascertain that basically you produce dizziness or nystagmus in those cases. You hold their head sitting down on an edge of the couch, suddenly lie them down and turn their head slightly lower than the couch and wait for 30 seconds. What you're trying to do is you're trying to produce either nystagmus or vertigo. And the state, the head is down, the problem is on that side. Migraine, common, usually preceded by a typical aura. Patient has previous history of migraines, a lot of nausea, headaches, vomiting. Make sure you differentiate with migraines from some causes of TIAs we will discuss in coming slides. Meniere's, I think we had a little on that. It's usually increased endolymph pressure, tinnitus, and hearing loss. Now, as an ED physician, our role is to make sure that this cause of dizziness or vertigo is not central. As long as we can do that, you should be okay and your patient will do fine and will not have any untoward outcome. The central causes could be TIA, strokes, multiple sclerosis, brainstem infarction, or cerebellar strokes. Now, once you know that this patient have peripheral cause of his vertigo, then there are certain medication which you can prescribe. In a different part of the world, they treat them differently. We use lots of benzos. We use also centrally acting antihistamines. I personally use Stemetil. That is how I train and learn from UK. People use metoclopramide, but be wary of metoclopramide using in especially young female. They can get quite significant oculogyric crisis and can have some side effects. So this is the real bit which I want to come on to, dizzy plus. So patient who don't have any symptoms or signs of peripheral vertigo or peripheral cause of dizziness, they might have something else going on with them. What is that? So usually in the central causes, as we earlier alluded, the nystagmus is either rotatory or vertical. It can be horizontal, but most of the time it is rotatory or horizontal. It's bidirectional, so it changes with the direction. I have a little video I'll show you in a minute, which will explain in detail. And when you fix their gaze, the nystagmus does not suppress. Learning by patient with a cerebellar or stroke or transient ischemic episode usually have coexisting risk factors and present with very sudden onset of central vertigo and symptoms. So they have some underlying risk factor for vascular events, age, and other risk factors. Okay, so people who don't have an access to immediate imaging MRIs or MRAs, this test is a fantastic tool for you to investigate and test that this patient, whether this patient is having a central or peripheral cause of dizziness. And usually, remember, in benign position of vertigo, we did Dix-Hellpike on those patients who had an episode of dizziness, but when they come to ED, they don't have vertigo, they don't have nystagmus, they feel okay. But in this case, you have to have ongoing vertigo and nystagmus. So don't do this test on patients who don't have vertigo or nystagmus at the time they presented to ED.
The HINTS exam is used to reliably diagnose vestibular neuritis and thus rule out stroke. There are 3 components to the HINTS exam: nystagmus, test of vertical skew, and the head impulse test. Nystagmus you observe in primary gaze, where they're looking straight ahead, and in lateral gaze, where you ask them to look to the left and right. In this normal volunteer, she has no nystagmus. Now, when you ask them to look laterally, they might fixate on your finger if you put it there, or something on the wall. So in order to take away fixation, which can suppress the nystagmus seen in vestibular neuritis, you can place a piece of paper between their head and the wall and ask them to look at the wall as if the paper isn't there. That takes away fixation, and you might see nystagmus, which you wouldn't see without the piece of paper. In this patient with vestibular neuritis, observe his nystagmus.
Just look to the left again. And then to the middle and to the right.
Here it is again. When he looks to the left, his nystagmus increases. It's left beating, and there's a rotatory component towards the left, and it increases when he looks to the left. You can see the torsional component. And when he looks to the right, it lessens, but the fast component is still towards the left. So it's unidirectional nystagmus. It doesn't change direction. In the HINTS exam, this is reassuring. Compare that to this lady, who, when she looks to the right, she has small horizontal nystagmus with the fast component to the right. I showed this short clip twice just to see the little rightward beating nystagmus, and then when she moves more central and to the left, you can definitely see that her nystagmus is now beating towards the left. So she has direction changing nystagmus, or bidirectional nystagmus, and that's worrisome in the HINTS exam. The next component of the HINTS exam is the test of skew. You observe this by doing the cover-uncover test. You simply take your hand and place it over the patient's eye and move it to cover the other eye, and observe if there's any vertical movement of the eye when it's uncovered. In this patient, observe how when I first take away my hand from his right eye, that the right eye will go medially and upward. And then when I take my hand away from the left eye, it goes medially and downward. It gets a little less as we go along, but there's definitely some vertical skew deviation, which is worrisome in the HINTS exam. Upward and medially, downward and medially, upward again. So this abnormal vertical skew deviation is worrisome in the HINTS exam. The head impulse test will be abnormal if you have vestibular neuritis. The head impulse test is looking to see if you have a nerve problem. And if you have a nerve problem, you probably don't have a brain problem. So it's a little counterintuitive in that an abnormal finding is a good finding. In order to perform the head impulse test, hold onto their skull, have them look at your nose or the camera, and then move their head back and forth until you're sure that their neck muscles are relaxed, and then in a random fashion move their head briskly to the midline from maybe 20 degrees out. What you're looking for is an abnormal catch-up saccade, which I'll demonstrate shortly after this normal volunteer. So again, holding onto the skull, moving the head slowly to relax them, and then moving their head briskly to the center and looking for any abnormal movements. Her eyes remain completely fixed on the camera, and that's a normal thing, which in a normal person is good. If she had a acute vertigo lasting hours and days and nystagmus, it would be bad. Here is an abnormal head impulse test. Notice how this man, initially you can see some nystagmus when he looks to the left beating nystagmus. Then when his head is turned to the right, you'll see the catch-up saccade. This is normal, that one. The next one will be the catch-up saccade. Did you see how there's a larger movement of the eye from the right to the back to the midline? That's an abnormal head impulse test, which is reassuring in the HINTS exam because you're showing that he has a nerve problem, probably doesn't have a brain problem.
Sorry about the long video, but I thought unless we show this video, it will be very difficult to convey how exactly you do these 3 tests. So essentially, we already done this. The reassuring hint exam is if you have you look at 3 things. You do the nystagmus, head impulse, and test of skew. They all amalgamate together and give you a rough idea that is it something serious or it could be peripheral and patient can be discharged. So reassuring hint exam is if you have a unidirectional nystagmus, positive head impulse. So here head impulse test is telling you this patient problem is in labyrinth or vestibular nerve rather than central. And then no vertical skew. Vertical skew is very important. Actually, head impulse test, they say, is extremely specific for peripheral region. Its specificity goes up to around 100%. And worrisome hints exam is if patient have direction changing nystagmus and they have normal head impulse. So normal head impulse is not good. And they have an abnormal test of skew. So which patient do you perform the hint exams on? Patients who are actually vertiginous when they come to ED and they have the nystagmus. When do we perform the hint exam and Dick-Salpike test on the same patient? Anyone? So hint exam and Dick-Salpike on the same patient. Hint exams, hours or days of work, we only perform hint exam if patient is having acute vertigo and they have nystagmus. Dick-Salpike, we performed patient who has a short, brief episode of vertigo, and when they come to ED, they don't have nystagmus. So answer is never. So you don't perform both tests on a single patient. Before I go to summary, the most important point I want to take you away from this afternoon is make sure the patient who have had dizziness and if they have any other worrying symptoms, for instance, and they have underlying risk factors, elderly, diabetics, hypertensive, hyperlipidemic, and smoker, they have a risk of having something central, TIAs or brainstem infarction or cerebellar strokes. The evidence is if somebody who presents to your ED with a dizziness and they have 1 or 2 underlying risk factors, they would have had stroke a risk of around 8 to 10% in the next 2 years. And if they had more than 2 risk factors, they would end up having the risk of them having stroke around 14 to 20%. So the key is to differentiate those patients who have had possible central cause from the one who have peripheral causes. So good history is a key, whether the vertigo has been brief, has been insidious in onset, any hearing issues, has it happened before, and is there any underlying risk factor for having central problems? And then nystagmus. So a lot of examination. Now every single dizzy patient, I told my residents, make sure if they have ongoing dizziness and nystagmus, you do hint exam. Whole good neurological exam takes only 2 minutes to do it, including all cranial nerves exam. And this, if you see, once you start doing it, literally 30 seconds you can do the hints. So there are a lot of videos and on the YouTube and everywhere for hints exam. Please watch them. And it's a very nice little elaboration and up to date also. If you want to go and have some bedtime reading today. And with that, thank you very much for listening to me.
Thank you so much, Anser. Does anybody have any questions?
Please.
Coming.
Yeah, have the mic.
First of all, thank you very much for the nice talk.
Thank you.
My name is Mateen. I'm a ED physician in Brisbane. This is a BPV is very common presentation, and they have a recurrent presentation. So sometimes they have a very fine nystagmus, which you're not able to appreciate by looking just with the eye. So we have goggles, which our vestibular physios use it, and they can see that definitely the patient have nystagmus. So then the vestibular physio do all this tests and everything like that, and the patient feel quite well soon after that. So nystagmus, what I'm meaning to say that nystagmus can be very fine. So you cannot be always rely on the nystagmus differentiating between the peripheral vertigo to the central cause of.
Absolutely. You know, the goggles are brilliant, but if you don't have goggles, you can use a paper so that the fixation goes, because imagine the patient looking all the way to the right, and meanwhile you lose that small this trajectory moment. So you can use paper, which will do similar good as the goggles. The other thing you can do is to use the light. So light will also improve your success of picking up the nystagmus. If you have goggles, that's brilliant. That's something probably we need to ask our ED guys to get it for us.
I think it's an excellent tool, and is really not very expensive at all. So I think every department should have that. So it really helps in making your decision whether you want to send the patient, because not every ED in Australia have MRI facilities. So you can do CTA, but that's not going to exclude
So
posterior circulation to stroke.
So it's a good point. When it comes to imaging for the possible posterior circulation strokes, CT itself is not a great tool unless you have to cut it really thin. CTA may be also not very sensitive in first 6 hours, but yes, after 6 hours, CTA is quite gold standard if you don't have MRIs. MRI will pick anything and everything within first hour or so, or MRA.
Any further questions? Great.
So everybody is expert in dizziness and vertigo right now. No questions.
Great. Thank you, Anser.
Thank you
really
very much.
appreciate your insights. Okay. There is a little bit of food and tea and coffee still available. Take 5 minutes to stock up. I can highly recommend the soup as well with the meatballs. It's an Indonesian delicacy, so there's some of that left, and I would highly recommend. So meet back here in a few minutes for the next session. Thank you. So, hey. All right, can you? Okay. Thank you, everybody. So, what we're going to do is we're just running ahead of schedule. So, we've got, we're just going to do something a little bit different. And our guests from Dubai have graciously offered to form a little bit of a panel for a Q&A session. So we're really lucky because we have these international guests. There will be a QR code displayed on the presentation behind me. If you want to submit a question for our doctors, then please scan this QR code now and it will populate onto the screen and we'll be able to have an interactive and engaging dialogue. So please do that now. Think of your questions while we welcome up our doctors from Dubai. Yes, please. Thank you for joining us. This is exciting. Okay, so our first question comes from Anonymous. Wonder who that could have been. Provide some of your background. How did you get involved in medicine and what made you move to the UAE? We'll start with you, Hamid.
Thank you. So basically, background, I was graduated from Pakistan and then moved to United Kingdom, UK for my training. So I worked in Manchester and for 14 years and then decided to move to UAE for different reasons because it's closer to Pakistan where obviously my home country is, so easy to fly in and out and try something different and different opportunities. So I work as a associate program director for EM residency program, and we have 32 residents in our program. We take 8 residents every year. Along with that, I work as an assistant professor in UAE University where we teach and train undergraduates. Weather is a bit hot, but summer are lovely, winters are lovely there. So there are a few reasons why I decided to move to the United Arab Emirates.
He didn't tell you the real story. He didn't tell you that I brought him to Dubai. So we both trained in UK. How I ended up in Dubai was just pure accident. One day we were at work. One of my colleagues, he used to do moonlighting or locum in Dubai. So he got an email that they need somebody for 3 weeks. And he didn't have enough annual leave left. So he came into my office and said, "You want to go and work in Dubai for 3 weeks?" I said, "Yeah, why not?" I asked my wife. We had 2 small kids. So they take care of your flights and give you accommodation. So you have a paid holidays. And obviously, I'm also from Pakistan, close to the family. Parents were getting old, so you can easily go up and down to Pakistan. And absolutely, we thought we were going to move for 4 or 5 years, but we've been there for now 10 years. Lovely place to work, nice people, good food, and Dubai is hub, easy to travel anywhere over the world. So if anybody is interested, I cannot vouch enough. It's a great place to work.
Thank you. I think this next one here ties quite nicely onto the back of that question. Would you consider working anywhere else in the world, and why? I see maybe you're trying to poach some of our doctors to the UAE. Potentially, this is going the other way around.
You know, as you move along in life, things change and your priorities changes. And now the situation of life we are in, your family and your children takes the priority. So kids are growing up, and my daughter, she wants to go and do medicine. So if anywhere I had to go for work, it will back to UK, mainly for university education. Otherwise, we have had offer, Saudi Arabia and Qatar and other places, but so far we found, Dubai is the best place for work and for social life, and for children also.
Absolutely, Anser. We have to. I'm thinking my circumstances. So if I have to move, I have to move with my children basically. So my daughter has already started university in Lancaster, and she's doing medicine first year. So we were already kind of thinking about it. To move back at some point. So it's difficult to go far. I think I am at that stage where to just like stay focused and start wrapping up things rather than moving too far. So I will think twice moving into another country for working, basically settle down now.
Thank you. If you could choose another specialty, what would you choose and why?
So I'm a training program director for ER in Dubai, and when residents come for visit, pre-registration visit to the hospital, and they're still not sure which specialty they're going to go with, I tell them best specialty is ED. Choose it with eyes closed. Some people argue that it's not very social and family-friendly specialties. You're doing, nights, weekends. Sunday morning you're at work, and the whole car park is empty, and everybody's either playing golf or having a lie in the bed, and you're at work. But it's that sense of satisfaction which gives you for treating acute, unwell and critical patient, one, and second, once I've done my shift, nobody will call me. I'm home, everything's switched off. The work stays at work. You don't get any on-calls call, which you do in other specialty. If I had to choose, probably if I given a second chance, I will still do ED, but for question reason, probably ICU.
Yeah, emergency medicine is obviously a very challenging specialty, but once you join the emergency medicine, I myself wanted to be a surgeon for many years before I joined emergency medicine. But when I look back now, and obviously quite content when I settled in emergency medicine and look back the things I've achieved, they are pretty, kind of marvelous for me. And there are definitely opportunities in specialty. There are big plus points. However, obviously, if you don't like shift work and evening and nights, then obviously this is something can be challenging. But you get used to it with your pace of life. We liked having a weekdays off. Which in 8 to 5 work you don't have weekdays off. But on the other side, you do have to do weekends and nights more than other specialties. But there's a lot of positives in emergency medicine. Like Anser said, don't get disturbed. Once patient is moved out of ER, it's not your responsibility. So you do some good stuff which give you satisfaction when patients are happy, and like dislocated shoulders and stuff like that. We have our colleague who had yesterday problem with the hip. So definitely there's a plus points, and I would recommend, obviously you have to have a specific personality to join emergency medicine. And if I have to choose at a second thing, I will probably choose anesthetics. But ED is still my first choice.
Amazing, thank you. This one will be interesting. What are some of the most common ED presentations that you see at your respective hospitals? And I wonder how that compares to what we see at ours.
Dizziness. I work in a private setup. It's quite a busy private hospital, unique in terms of it's 24 hours consultant delivered service. So we just started residency program. It's the second year in very nascent stages, and we only have 2 residents so far. But it's completely, every single from cough, cold to ear pain to strokes and trauma and MIs is seen by yourself. A commonest presentation, there are lots of chronic diseases back in UAE for weather and dietary reasons, lack of exercises. So we see a lot of acute kidney diseases, infections, especially I'm lucky. When I was coming here, I was reading Bali, which I haven't got so far. I hope no one else has got. There's also, Dubai, Bali, lots of, infections. And Dubai is also a health tourism hub. So we see lots of patients from Africa, so tropical diseases, malaria, which I don't know whether you see that in Australia. Heart diseases, strokes, young people. It's a predominantly young population. But due to underlying medical conditions and poor compliance, lots of strokes and MIs in young people.
Anser works in a posh hospital in Dubai, whereas I work in a government hospital, which is in Abu Dhabi, as a major trauma center and a stroke center. So we take anybody who walks in with an emergency life-threatening condition free of cost. So our workload is obviously, common presentations are common, but we will take anybody who presents with life-threatening emergency, be a stroke, a major trauma, people with MI. So the strange thing we see that young people presenting with stroke and MI in that region, especially from Asia, India, Pakistan, and Bangladesh, young people coming with a stroke, and the age threshold actually getting lower and lower. Along with that, because of very hot weather, we see young people having acute renal failure and stuff because working in hot weather and stuff. They're not looking after themselves. So that's another unique presentation, along with the normal ED presentations, obviously.
Do you see many mental health patients walk through your doors at all?
In the government setup, yes, we do. We have a psychiatry unit as well. So we have full mental health service at our place. And as I said, it's free. So we see quite a lot actually. People who have substance overuse as well. Medical legally, anybody who comes with psychiatric illness and substance overuse, we have to report to the police in Abu Dhabi. What about Anser?
Yeah, so anybody who has taken an overdose, alcohol intoxication included, we have to inform police. And police comes and interview them in ED. We have a very well developed only outpatient psychiatric unit. We don't have any inpatient. So people who are acutely suicidal, we transfer them to there's a specialized mental health hospital in Dubai. So they all get transferred over. Yes, quite a lot. Mostly nowadays, everybody is investing in stocks. So a lot of anxieties and, acute impulsive overdoses after losing dollars and dollars. That's also one of the unique novelty in Dubai.
That resonates with me. On that, what would the police, out of interest, do when you report those patients to them who have come in with overdose?
So the police function is just to protect the patient and family, basically. I mean, obviously, if somebody is only alcohol, they will just make sure that it's not anything else is involved. Patient is okay, family is okay. And I mean, as long as they're informed, they're happy, they let them go. But if you've done kind of drug overdose, which is prohibited drugs, or suicidal attempt, obviously they are involved with you and they will interview you once you medically fit and discharged from the hospital.
I have an interesting story to tell you. Only 2 weeks ago, it was morning shift, 7:30, the ambulance brought an 18 years old local Emirati girl with abdominal pain. So I went in and, started taking history. I said, what happened? And she started crying. She said, don't tell him. I will give you the real story if you won't tell anyone. I said, this is confidential. I'm not going to tell anyone. Tell me what happened. And this girl has taken 28 tablets of paracetamol. So obviously, treatment was commenced and medically she was taken care of. And as a legal obligation, I have to inform police. So interestingly, if somebody in Dubai takes an overdose, in worst case scenario, they will be jailed for 6 months. If doctor does not report that to police, doctor gets jailed for 5 years. So, when she, obviously we start medical treatment, couple of hours pass by. So I go back, I said, listen, I need to tell police, this is a police reportable medical condition. So she absolutely went mental and, shouting, threatening to leave. So sometimes, things can be very complex with cultural background and the taboo which leaves, which they feel will leave them a bit awkward in the society. But so we managed to, get parents involved and family and, managed to calm her down, and police came. Usually come and have a brief interview. As long patient is in hospital and safe, then, once they get discharged, they probably need to visit police station once just for paperwork reason. If they refuse treatment, then police will take them with them.
Very interesting. We'd have no police officers, no jail space, and no doctors left, I think. Okay, next question. Do they employ nurse practitioners in ED or any other areas in the UAE? Who's best to answer that?
So far, there is no associate physician or nurse practice job in UAE. Up to a couple of years ago, most of the healthcare was government-led, so a lot of money pouring in. So, even where you can employ somebody who might do the same job, they had money to employ a doctor. But I think now things are changing. There is even the government setting is now being run by private sectors. So a lot of changes in salary structure and moving of doctors. So I think in a couple of years this definitely will come in. But people are with experience, they're taking like nursing supervisor jobs, other admin jobs, and later on they perhaps will be able to get the more clinical work.
Thank you. And final question before we wrap up. Dr. Hamid, from your experience, how has trauma resuscitation evolved over the past decade, especially regarding permissive hypotension and damage control?
Well, we have, keep seeing changes in trauma resuscitation, and every 3-4 years you get new guidelines and you move on from the previous ones. In case of, this tranexamic acid use in trauma, and now we got recent guidelines using 2-gram bolus. So there is continuous movements, evolution happening in trauma management. we are getting to get 11th edition of ATLS. There are new guidelines coming in there as well. So permissive hypotension is important. You can use it for first 20, 30 minutes. Basically, it's just an idea so that you can keep your bleeding to minimum and you have a small clot which is already established. And you don't want to dislodge that clot basically. So it works if you keep it to minimum duration, half an hour, 20 minutes, and get to the definitive hemorrhage control. If you're going to keep it for hour, 2 hours, I mean, it's not unfortunately going to work. You have to go to the definitive management. So this permissive hypotension is also important that this concept is also only works in patients who are having active bleeding. In patients who have a blunt trauma and the traumatic brain injuries, permissive hypotension is not supported there. There you have to maintain blood pressure close to normal as much as possible. Hence, the guidelines are to manage blood pressure on 90 to 100 in bleeding patients and 110 and above in patients who have a traumatic brain injury. So I'm sure you're going to see some more guidelines in next 6 months and years about trauma management.
Thank you so much. One more.
No question, just the little statement. Thank you very much, Paddy and team, for organizing such a wonderful conference. I think I really like the idea of having short days of didactic teaching and leave rest for activities and sightseeing, networking. We thoroughly enjoyed it, and I hope you guys also had and will have a lot of fun in next 24 hours. Thank you.
No, thank you. I put them on the spot for this, and they're so gracious that they have come up and formed this panel. It was really insightful, and I appreciate you both sharing your expertise, your insights, and thank you very much for the kind words. Big round of applause, please. All right, we're just going to have 1 minute. We've got one last presentation, and then we'll go out and see the rest of Bali for the rest of the afternoon. Don't go anywhere. Basically, how can I summarize Grad? Hanging around our last presentation, we're really lucky. We've got Jessie Bange, clinical nurse specialist, mentor, educator, clinical educator out of Monash University in Melbourne, Victoria. Please make her feel very, very, very welcome. Thanks, Jessie.
Hi everyone, my name's Jessie and I am a clinical nurse specialist and sessional academic for both Peninsula Health and Monash University. I'm currently working on an orthopaedics and plastics ward and am often assigned as preceptor to graduate and to undergraduate nurses. The ward which I work on became the overflow ward for COVID patients, which meant that every time an outbreak in the community would occur, our ward would need to flip between our regular plastics and orthopaedics patients and into respiratory and COVID. This pretty much meant that we had to get used to shifting back and forward more times than I can remember or anyone else who I was working with, and that, as you can imagine, was particularly difficult for our junior staff. We would adapt, then we would adapt again to dynamic changes in the war against this virus, and I would frequently witness these novice nurses struggling through their shifts. I wondered at times if these experiences were strengthening their skills or setting them up to fail. This research was completed as my honours degree project and funded by Monash University. This explored area of interest is the Victorian employed graduate nurses' experiences of support, training and education within their first rotations during the pandemic. We all know what a graduate nursing program is, and we know what the importance of support, training and education is. This is what is generally provided within the 1,600 of these invaluable roles which are offered across Victoria annually. Guiding graduate registered nurses through their transition into independent practice and consolidating their knowledge and skills can provide all of our hospitals and communities with a large sustainable workforce. We need these confident future registered nurses to do the best that they can during these graduate programs because they will be the future who will be caring for all of us. Organisations, healthcare organisations understand the challenge of this daunting, anxiety-provoking period for graduates. Therefore, these roles include mentorship and preceptorship, which is provided by experienced nurses, experienced multidisciplinary teams. This can safely transfer the knowledge that we all have into the practice of the future. Additional workplace supports of nursing educators also facilitate learning through the collaboration of academic and clinical practice elements. Training should focus on clinical judgment, critical thinking and interdisciplinary teamwork. This is imperative to skill consolidation, role adjustment and creating a safe and ethical workplace culture. Including significant constructive feedback, encouragement and also debriefing is really important as these nurses are vulnerable to negative mental health outcomes and professional burnout, as well as developing inadequate, unsafe or ineffective workplace practices. COVID-19 unfortunately affected healthcare, graduate nursing programs and the graduate nurses themselves. Already stretched healthcare systems are feeling additional pressures of increased patient numbers, decreased available staffing, and all of this was further affected and compounded by the new pandemic-related jobs that also required filling. The best people available to fill these roles were those clinical support nurses, clinical educators, the nurses who weren't required for patient care. When these new graduates are susceptible to these increased exponential exacerbation of fears and interruptions to further education, they also had to adapt to cope with expectations and emotions of patients and their families during the COVID-19 pandemic. The aim of this study was to describe newly graduated registered nurses' experiences of their workplace support, training and education during their first rotation of their graduate roles in Victoria. This is important because if we go through several years of graduate nurses not getting what they need for support, training and education, what will happen beyond that? What will happen in 5 years from now, 10 years from now and into the future? New graduates are really needed to give not only surveys and quantitative results, but also to give their qualitative answers and interpretations of what is actually happening. When we considered this design approach, we used qualitative research, which sits in front of the interpretivist paradigm. We sought to discover all of this information through our qualitative data collection and the value and perceptions afforded by graduate nurses to their own experiences and perceptions of education, support and training during that first rotation. Our findings established common themes between participants and their individual realities. This was clarified through these chosen paradigms whilst considering both subjective and also objective aspects. Data collection occurred through individual semi-structured Zoom interviews with an average duration of 45 to 60 minutes. This gave the graduates an opportunity to feel comfortable and relaxed, give us their true perceptions of what had occurred. They were graduate registered nurses during the pandemic in 2020, 2021 and 2022 in Victoria. We recruited through purposive sampling with the assistance of the ANMF, also through convenience sampling of personal contacts and snowballing where recruitment could continue through the word of mouth between these graduates. The Clark and Braun 6-step framework helped us to identify the themes which addressed the research subject and also interpreted and clarified our data. Systemic coding of interesting and unique facets which was found within these audio recordings was also followed by establishing applicable themes. These were then reviewed, labelled and defined for report writing. The demographic information which was collected during this study provided for data context and analysis. Demographical questions which were of interest included age, whether or not English was the first spoken language, and if a gender was identified. Furthermore, participants were asked about their first rotation ward descriptions and the settings, whether they were regional, metropolitan, public, private, the number of rostered shifts per fortnight. We felt that all of these factors could give us a clearer picture of whether or not our results were varied or were quite specific to a certain setting for these nurses. 3 themes organically evolved through the data analysis. They included transition to practice and 4 sub-themes of pandemic graduate nurse, practice readiness, emotionally challenging, and coping mechanisms. Secondly was development of graduate nurses and its 4 sub-themes. This included learning and professional competency, reduced, delayed or lost education, role of the educator and self-education. And lastly, support of graduate nurses and 3 associated sub-themes. These included formal support, informal support and seeking support. I'm going to be discussing 4 of these sub-themes today. Transition to practice. A significant absence of educators and experienced nurses meant that pandemic graduates were often allocated to perform as undergraduate preceptors or even without any warning or any training as the nurse in charge themselves. One participant stated, they couldn't get RNs. There was a shift where I was in charge as an RN and I was a grad and I don't have an educator. They just had all this trouble getting staff in because so many had left. I was surrounded by ENs. They needed me to approve giving Panadol. They needed me to approve giving wound changes. I'm a grad and you're asking me for permission. And they don't have any senior RNs around. I've never done an in charge. I don't know what the hell I'm supposed to do. Unknown COVID-19 processes and redeployments to unknown settings evoked stress, patient safety concerns and negativity towards their organisations and their career choices. Graduates felt immense pressure whilst challenged through both their new careers and navigating COVID-19 specific requirements. One participant reported. Also, time constraints. Being a new nurse, you're not very good with your time management. You're still trying to figure all of that out, and then all of a sudden you're having to factor in additional PPE, ever-changing PPE as well. Practice readiness. Underpreparedness in adapting to pandemic requirements was voiced, especially due to final university studies having been online. Participant 3 shared her experience. Pretty much on my first day, kind of on the floor, I didn't feel like I had a set of training wheels on that you'd kind of expect. It was very much like, here's your patient load, good luck. Like you've almost got someone's life in your hands, and having 2 years of online learning for uni, and then all of my classes were 1 day of practical, which went for 8 hours. That was my practical learning all semester. I don't know how much you can really learn from that. And then I meant to put all of those skills into starting on the floor. So that was really challenging. Shift work adjustments, COVID-19 challenges, and limited educators and preceptors equated in reduced support and education. This made many graduates question their nursing abilities. One stated, "I felt that I was incompetent, I was incapable, that I should know more, it's my fault because I don't know more, because I'm not seeking these learning opportunities, or I don't have, my time management skills aren't good enough. I felt very underqualified just for doing the basics of nursing at that point in time." Graduate nurse development, learning and professional competency. This aspect of programs contributes to newly graduated registered nurses' skills and competency while supporting their development, competence, and growth into capable registered nurses. Face-to-face teaching was often replaced with inopportunely scheduled online sessions, often with no replacements offered if they conflicted with work-life balance or with rotating rosters. Ad hoc training was limited, and many graduates yearned for additional learning. This resulted in graduate nurses losing the ability to practice new skills, ask questions, or reinforce the knowledge that they had learnt in university. One participant stated, "The biggest challenges for me were the lack of educational opportunities, the lack of psychosocial support. I felt like I should have known more, and I should have been more capable and more confident. But it didn't happen. I felt that I was incompetent." Although graduate program structures across organisations were similar in appearance, graduates voiced variations in delivery and organisational expectations. Some participants described clear competency guidelines. Other participants described instances of having very much limited guidance, such as, well, competence-wise, we had to do our own medication one, but that was very much self-guided. I never got an educator to supervise what I was doing. It was always my colleagues, or even when other grads had gotten theirs signed off, we would just kind of supervise each other because there was no one else around. Whether or not training and education were implemented as a core element embedded within graduate roles significantly varied between organisations. The outcomes for these newly graduated registered nurses also varied. Some reported contentment with significant professional growth and clinical skills. However, most of our participants felt that their professional achievements were lacking. Consequently, they either thrived under self-ambition or crumbled, feeling that they barely made it through. Support of graduate nurses seeking support. Most participants perceived that searching for educational support through self-advocacy was necessary, as it was not readily available or offered. Participants described ever-changing pressured environments with dynamic workplace requirements and stretched resources. This resulted in inexperienced staff often providing preceptorship, which participants felt decreased its value. Instead of being offered continual assistance, they were forever pleading for it. One participant stated, "You need the other people that are there to be willing to teach you. That would be great. I don't know how you make that happen other than a cultural change, or I don't know how you would mandate that either. You probably can't." Responses to requested support for graduate program information or managing burnout symptoms also varied. Some organisations provided abundant assistance beyond the graduate nurse's anticipation, whilst other graduate nurses applied through several avenues and were often met with negative responses and the omission of the support that they so much desired. One participant outlined, "When we did ask for support, it was, well, everyone is struggling at the moment." Yeah, I understand that everyone is struggling, but if someone's coming to you and saying, "I need help," isn't there a big push for mental health? When we're all saying, "I need help," oh, well, you'll have to do better with your time management, or you need to find ways to decompress at home. That's not very useful. Confidence and encouragement is instilled in newly graduated registered nurses when organisations appropriately implement adequately supportive roles and achievable programs through management of their education teams and their assigned preceptors. Job satisfaction and retention rates within evolving workplaces increased when clinical judgment and competence can bloom. This study uncovered the unprecedented uncertainty which was thrust upon pandemic graduate nurses. The reported unpredictability of their graduate program conditions and orientation periods did not meet their expectations. Programs should have encompassed supernumerary orientations with supported competencies and assessments, debriefing and educational sessions. Unsupportive role commencements contribute to lost, non-sequential education and training opportunities, which further results in prolonged learning curves, maladaptation, disappointment, vulnerability and concerns for everyone. Educators and their teams were often absent or non-existent within the facilitation of these programs. This creates an accelerated learning pressure and the requirements for self-educating at the graduate nurse level. It was expected that the graduate nurses would find their educators to have their education facilitated and that these programs would be well coordinated, that they would be accessible and approachable for potential learning opportunities. Their absence was directly attributed to the negative role experiences that these graduates had. They self-perceived incompetency and professional inadequacies without encouraging feedback and strong mentorship. This further impacted their confidence, practical learning, clinical thinking, and critical skills that they needed. Dynamic workplaces, ever-changing protocols, infection control, and medically demanding COVID-19 patients plagued these newly graduated registered nurses. This was further amplified through the either reduced or non-existent breaks that they were receiving, and workload pressures, including staffing requirements for them to pick up additional shifts. Understanding that the pandemic has permanently changed graduate roles is really important because that enables future program restructuring to guide graduate nurses through their transition to practice. This transformation of skills which they can achieve within their roles and also can be encompassed within current programs but future programs can help to incorporate the realisation of potential future critical healthcare system events, anything else that might occur in the future, not necessarily another pandemic. Producing an enhanced and sustainable future nursing workforce requires supportive training and education. Providing new graduates with empowerment strategies for seeking assistance, debriefing, and equitable rostering will encourage their resilience and a strong work-life balance. Without a doubt, pandemic graduate nurses have felt that their education and training opportunities were lacking and did not meet their expectations. Whilst new to clinical practice and adjusting to all of the demands of a nursing profession, they have also had to endure substantial routine disruptions and cope with their emotions and expectations whilst beginning their careers at an unprecedented time in healthcare. The question now is, are these pandemic-trained graduate nurses prepared for their roles as graduate nurses? Some of them are a couple of years out now and may even be moving into senior roles. Will they be capable of performing as future nurse leaders and mentors themselves? What will these years of substandard graduate programs mean for the future of nursing, and can that be reversed? Thank you everyone for listening.
Okay, we're on. Thank you, Jessie. Any questions for Jessie? Coming down.
Hello, thanks for that. I was just wondering, as a result of this study, this research, if you guys thought that there needed to be improvements in the way that nursing education is delivered as an undergraduate course to prevent some of these issues that nurses maybe aren't work ready when they finish in Australia. I know that models are they look a little different in some countries as well, maybe a bit longer undergraduate, but they might be more prepared as a graduate when they're ready to work. They're ready to work. They don't need a program for a year to assist them in finishing their sort of skills completion.
Thank you for that question. So we did think about this as well, what can actually happen in the future, and obviously that will be for other people to pick up the research as well, but I am currently a PhD candidate and I'm working on a new scoping review which kind of moves into that as well. So like you said, in other parts of the world, the bachelor degree or equivalent is often 4 years, which gives that last year to complete additional hours. Not sure how that would sit in the Australian education field, but I think that with a change now moving into paid clinical placements, there is potentially room to extend those placements, and that could be something that would be really interesting to look at for registered nursing, because it would certainly provide additional time on the floor, more clinical practice. And what we found, what we were told by these participants, is that there certainly wasn't enough clinical preparation, particularly during COVID, but they still received the same amount of clinical hours in placement. So we were certainly told by these participants that they felt underprepared.
It's interesting because even myself, I graduated nursing in 2012, and from the beginning of my degree, which was 7 semesters, to the end, the placement time that you were sort of told you would get throughout your degree was reduced by the end of the degree, and that was put back onto the WA health sites as saying that there's reduced capacity for mentorship, all these sorts of things like that. And it was funny because I actually did part of my degree internationally, and I completed it with some people from Canada, Sweden, Denmark, and actually Tanzania. And the Canadian nurses, they have just as a point of, I think it's really interesting, they actually each semester have a home ward, and quite often it wasn't just a surgical or a medical ward, it could be also a crit care area, and they would go to that ward once a week, and then that's the same ward that have their prac. So by the time they already got to their prac, they were familiar with the ward, where everything was, how things processed, they knew what their goals were, and that happened every semester for their degree, and then they come out like work ready. And it's just a really interesting design, I think, compared to my experience and the experience of many of my peers. I felt even at that time, you were getting over-promised, under-delivered practical times, and it's always sort of stayed with me that I think it's probably under-preparing our nurses, and we rely on these grad programs. So, yeah, I just thought that was interesting to know.
It is an interesting concept. What I'm finding at the moment through what I'm researching into a scoping review is that unfortunately it seems as though globally the retention numbers for nurses in the first 2 years is similar across the world. So I don't really know how we go about addressing that, because it doesn't seem to matter, in countries that have these longer clinical practice hours during their undergraduate degrees, whether it doesn't seem to matter whether they have the longer hours or the less hours. However, what potentially does matter is their clinical skills, their job satisfaction, all of those other things. So that's what would be really interesting to look into, whether or not that might happen in Australia.
Thank you.
Hi, that was a really interesting presentation. I'm coming from a New Zealand perspective, and we have so our nursing council recognised that there was attrition rates in newly graduated nurses a long time ago, implemented the first year, supported, as you described. I found it interesting that, yes, it looks, we've identified that that's a way of supporting nurses and that's what they need. And then obviously because of the stresses of the pandemic and everything, the first thing to go was that. And I think it would be interesting to see how well they transition later on, because we saw in our department, as you described, like new grads, they hadn't even finished their first year and they're a preceptor, and you can see the gaps in their knowledge, and it's not down to the fault of the preceptor or their new grad or their student. You can see that there's gaps in knowledge, gaps in practice, and the stress that must be on these people. But our government is now proposing in New Zealand to reduce the amount that our new grads are employed, so they can't have more than 0.6 now, FTE. So that's less of that clinical time in that first year to consolidate their learning, and also, the amount of money that they can earn as well. So they've got to go still do those. We haven't got paid placements yet here. So I just think sometimes the education and the transition for our new grads seems to be just undervalued and not recognised, and the first thing that they do is they pull educators and they pull clinical nurse specialists away from them. Probably just an observation, sorry.
No, I completely agree with you. And I think that what we're going to see moving forward is not necessarily going to be much of a quick fix, because as everybody anybody from Australia may know or may not know, in Victoria at the moment, we have got our highest number of graduate nurses coming out next year, but our lowest number of graduate positions for those nurses. So I'm not sure how that's going to look moving forward, because those new nurses are now not going to have graduate roles to move into either, and are still going to need to be able to move into the workforce. And that's who we will then be relying on. And like you say, they won't have those hours of clinical support.
Thank you. Any further questions? Amazing. Thank you so much, Jessie. Really valuable research that you're doing. Hopefully it moves the profession in the right direction. I will have you out of here.
Thank you.
Thank you. I will have you out of here by 4:25, I think. Two last things from myself. A couple of spots left for yoga and breath work for tomorrow morning. Yoga kicking off at 6:30 a.m. boardroom 2 downstairs, followed by breath work at 7:30. Some of the words used to describe from the participants of breath work this morning was transcending and levitation. So let that stick with you. Please scan the link in your event handbook to secure your spot early for the breath work and the yoga. There are a few spots left for the ECG workshop at 9 a.m. tomorrow, kicking off at boardroom 3 downstairs. So again, secure your spot via the link in your handbook. And tomorrow is our final session, 2 p.m. back here, tea and coffee and snacks served at 1:30 and a shoulder massage. But for those of you, again, wishing to organise transport to Damaria tomorrow evening for our closing party, then speak to Max, Delphine or Choc from Locum Life, or we can organise, again, we'll try and organise a walking group from the hotel to Damaria, probably depart here around 7 p.m. for a 7:30 start. So looking forward to that. I do have somebody's room key here, so if you're missing your room key, then please come and see me. Otherwise, have a wonderful evening in Bali and see you tomorrow. Thank you so much for attending.
Thank you, guys.